presentations, one after the other, with a very limited schedule? Yes, and the first question is, do you understand me? And any comment which improves communication is of high value. Thank you. So we should have some time after the presentations for questions. We get a visual summary by our expert of visual summarizing. And I think if the discussion is an ongoing one, we should move outside and have it informal, a little bit crowded perhaps. But I think we have to be fair to the next session. So I quickly jump into our program. Please, Daniel, present what you are doing in Spain.
Okay. Good morning. For those who can see me, I'm 55 years old. My height is 1.70 meters. I have a brown and white short hair, and I'm wearing a dark suit with a yellow tie. Is the healthcare system specialized in attending people with disabilities? Based on our experience, for people with disabilities and their families, visiting a healthcare center was a kind of nightmare. In the next few minutes, I will try to explain how we are trying to change this perception. I don't know if we have the presentation. No? Okay. We know that the families of people with disability have a very clear vision of what are their needs and the barriers they face day by day. In the case of the EASY program, it was a group of parents of people with disabilities who identified that the hospital environment was hostile for their children and themselves. Disability became more evident upon entering the hospital door. Diagnostic tests were difficult to carry out or were simply omitted, and the difficulty in communication created insecurity. Insecurity led to distrust, and distrust to fear. It was clear that a structural change in the way things were done was necessary. The other option was to resign oneself. But believe me, families of people with disability, they don't like the word resignation. As in many other areas, the healthcare system is not designed for people with disabilities in general, and especially for those with intellectual disabilities and autism. Communicative barriers that limit diagnosis or the medical guidelines to follow. Uncomfortable, violent, or unwanted situation for the patients, other patients, or professionals. Long waiting times that increase anxiety levels. Inability or difficulty in carrying out tests without resorting to drastic measures. The absence of a friendly context or an empathetic approach towards the person. In short, families knew that needed to be changed, but a diagnosis was required. For an effective diagnosis of the problem and the search for solution, working committees were created. Firstly, made up of families of people with disabilities from Fundación Personas who carried out an initial situation diagnosis, the true initial impetus of the AC program. Secondly, integrating the Association of Autism and healthcare personnel from the public administration. These working teams clearly identified the aspect to improve. The healthcare system did not consider measures for non-standard patients. Needs were not met due to a lack of information. There was no reference to promote in the system changes or adjustments. It was necessary to generate knowledge about disability at both academic and professional levels. The work of this team leads to one conclusion. Small changes, even without the need of extraordinary economic measures, resources, could improve the quality of the system. The key to success was achieving a high level of coordination among all the stakeholders. As a result, some initiatives were launched framed with a collaboration agreement between Fundación Personas and the Regional Ministry of Health. A pilot experience was carried out in one of the most important hospitals in the region. Joint workspaces were created for the exchange of information among social and medical professionals. Guidelines were established aimed to achieve a more comprehensive approach, what we call a decalogue. The value of the individualized care approach based on the experience and know-how of social entities was highlighted. And what does this individual care consist? Let's look at some improvements introduced in the system. Firstly, positive discrimination in access to the healthcare system had to be ensured. To this end, an automatic identification system was implemented in the healthcare management software. When a person with a disability requested medical attention, an AC alert will be triggered. This AC alert is associated with the activation of measures to anticipate the user's arrival at the hospital based on the person's needs. At the same time, the agreed protocols and action guidelines established in the working teams were activated. This protocol to access to the system was very important to ensuring the adaptation of the hospital context to the special circumstances of the user. Secondly, another key aspect of the program's success was the way information was managed and how knowledge was generated around disability. The AC alert and protocol activation becomes a very useful tool for identifying the target population, their characteristics, their care needs, or the frequency with which they require it, which allows to improvements to be introduced in the system. Furthermore, the AC program has made a strong commitment to the training of healthcare professionals through a continuous training program in competencies related to disability. Lastly, but maybe the most important thing looking ahead, a specialized subject on disability has been created in the university at the Faculty of Nursing, ensuring that future healthcare professionals are well trained in this area. This subject is one of the most valued by students according to the surveys conducted. Now, I would like to highlight the most important improvement introduced by the AC program. The creation of the position of case manager. This is a specialized hospital nurse. The case manager ensures the effective response of the healthcare system to the needs of the person with disability. The anticipation of the arrival of the patients with a disability reduces stress and waiting list. The case managers knows and understand the needs of the person with a disability and the flexibility of the healthcare system to facilitate a better hospital experience. It is a trusted figure that provides reassurance to families, especially in emergency situations. And most importantly, it facilitates quicker and more accurate decision-making in high-pressure contexts. The positive impact of the AC program is a fact, and also its future potential, scalability, replicability in other regions or countries. The current impact of individuals is reflected in the more than 3,000 interventions per year carried out in the AC program, with a very high level of satisfaction among the families and people with disability. The specialized training program in disability have provided coverage for more than 2,200 healthcare employees and over 500 university students. And in relation to institutional commitment to the AC program, there is a strong connection between Fundación Personas and the public health authorities. Once the success of the program and its acceptance by healthcare professionals were confirmed, the functioning of the system has improved tangibly. AC has opened up the doors to a different perspective on disability and a more human healthcare approach. To conclude, the AC program is officially integrated into the Plan Personas, which is the regional government strategy for the humanization of the healthcare system. The framework document of the AC program has been also published by the Regional Health Authority, providing us action guidelines within the entire system. Finally, this experience is not only applicable to our social context. We are convinced that AC is replicable in other regions, countries, or person profiles easily acceptable without the need to large budget allocations, and applicable in other unfriendly contexts, such as courtrooms or, why not, the police stations. In summary, people with disability and their families have a lot to say in the removal of barriers that limit their participation in the community as full citizens. We just need to ask them and involve them as promoters of a social change. Thank you very much.
Thank you very much for that introduction of a multi-layer approach to improve access, from giving information and training staff to fetching a person and his or her family at the door and safeguard the person through the system. I forgot to describe myself. I'm 67 almost, have little hair and a brown jacket. we have to continue from this wide, multi-layer approach to a very specific problem. People with intellectual disabilities and other specific needs have when it comes to dental health. And we are very proud that you show us an approach which reduces dramatically unnecessary anesthesia. Thank you so much for sharing.
Thank you. Who likes going to the dentist? 2 out of 200? 3 out of 100, 200. Okay. So just like you and me, most of us are afraid to go to the doctor, to the dentist. So this is you lying back on that dental chair, feeling very exposed, and the light hits in your eyes. You feel like you're going blind, and then you hear the noise of that thing, and it's in your ear, the noise of the drill. And what's that smell? It feels like something is burning in your mouth. And that taste, that unfamiliar taste, maybe that's that toothpaste that they use whenever they clean your teeth. So let's think about the exact situation, but you have a disability. So you're lying back on that chair, and you're not verbal, you can't communicate. So the drill hits your nerve, and you can't do anything. You can't tell the doctor, stop, it hurts. Or maybe you're a person with sensory processing difficulties, and so the light and the noise and everything makes you overwhelmed. So you can't do the treatment. You can't cooperate with the treatment. And the only solution is to knock you down. This is the default. So 45% of people with disabilities around the world are referred to general anesthesia for dental treatment because of lack of cooperation. And why is it so wrong? So maybe you have a disability and you need once in a few months, you need just a checkup or a cleaning or x-rays, but you don't wake up. There are health risks. And maybe you do wake up, but you're a 6-year-old boy, and then you see that they pulled out all your front teeth because they have to do the whole treatment in just one session. So they don't have the time to do the root canal treatment. So at our dental clinic at Bet Easy Shapiro, we managed to reduce that referral to general anesthesia to just 4%. My name is Shalhav, I'm a dentist, and I'm the medical director of the dental clinic at Bet Easy Shapiro. So we developed this dental model, and with the use of this dental model, we can reduce that number to just 4%. We treat each year 1,700 people with disabilities, and only 60 of them need general anesthesia. So Bet Easy Shapiro is an organization that works for people with disabilities, and it provides a wide range of services for children and for adults and also for families. But beside that, it develops new models. And these models are tested and evaluated, and then they are shared also locally and globally to influence systems. So this model is a game changer because it allows people with disability to be just like me and you. So I want to tell you about this model, but I want to tell you the impact that it has. How patients feel when they undergo the dental treatment according to our approach. So I want to tell you about Yohanan. He's a 16-year-old boy on the autism spectrum, and he's nonverbal. So for many months, he suffered from dental pain, but he couldn't get dental treatment because he didn't agree to even sit on the dental chair. So his parents, so finally he was referred to general anesthesia, but his parents were afraid of general anesthesia, so they decided to look for another option. So the first time I met Yohanan was at the parking lot, because he didn't even agree to come out of the car and to come into the building. So I sat next beside him, I smiled at him, and I said, "Nice to meet you, Yohanan. My name is Shalav, and I'm a dentist. And you know, when someone has a tooth that hurts, I know how to help." And I told him that today I just wanted him to go and to be familiar with the room, to see all the tools. But the most important thing that I told him was that I will never do anything without his approval, and that he will always be in control. And for the last 5 years, Yohanan is coming every few months for a dental checkup, and is able to cooperate and to receive the dental treatment that he needs. So our model is written, it's accessible. I teach at the universities, dental universities in Israel. I teach dental students the model, and I see that after this training, they feel otherwise about meeting a person with a disability. So I want to share with you, Yohanan is non-verbal, but he communicates by typing on his iPad. And so after every treatment, he sends me an email describing how he felt. And I want to share with you some of his words, because they really show the way he went through with us. "I've been to many doctors, and they all treated me as hostile. But you respect me and see me as a person. And I feel like an equal among equals here." So this is the result of a person-centered dental care, in which we see the person as someone who he wants to be an active part of the treatment. I don't want to do the treatment on him. I want to do the treatment with him. I want him to be an active part. And we do it with empathy, honesty, and a complete lack of judgment. The dentist turned the syringe into juice, the instruments into a spoon and fork, and the scary dental chair into a blanket and a pillow. Everything that was frightening became something good. So this is another pillar of our dental model, and it's adapted dental care. So we know that people with disabilities, they have barriers to dental treatment. So we don't ignore these barriers, but we work to remove them. And another pillar is also interdisciplinary approach. For example, we use visual communication cards, and we explain the patient step by step what tools we are going to use and the steps of the treatment. And so we can build the confidence and the cooperation. So as I said earlier, most of all are afraid of the dentist, but just like me and you, we all deserve dignified dental care.
Thank you so much for that important input, which has to be spread in all fields of our practical work. I remember patients sent with challenging behavior, nothing else than pain, unmet needs. Thank you so much, and we carry on to another project which was European-based to develop tools to improve knowledge in the healthcare field. Please.
Good afternoon, everyone. My name is Roberto Zanone. I'm 45, well, 46 actually. Brown hair, I wear glasses, and I have a blue sweater. I'm the head of projects at the European Platform for Rehabilitation. I'm going to introduce you to the Equal Treatment Project. Well, if you want to meet my colleagues at the European Platform for Rehabilitation, we have a table downstairs. We are an umbrella organization representing some service providers like you at European level supporting people with disabilities. As mentioned before, this project has some similarities with the one that was presented at the beginning by Fundación Personas, and actually the context that we identified is quite similar, but we work more on a European level rather than on local or national level. Given that it was a European project, we're happy to have here some of the members of the consortium. The project was implemented in 5 countries, and we had the participation of Tampere University in Finland, Fondazione Campos Arnau in Girona, and also the Girona Biomedical Research Institute, and I see the colleagues here, Kaunas College in Lithuania, a research center of biopolitics of Pantheon University in Athens, and Margarita, service provider in Athens. I would like to have the pointer. I remember now that I need that. And anyhow, I will skip maybe the part on the context analysis because it was already described properly by Daniel. First of all, we decided to focus on as broad as possible stakeholders. So we tried to involve as many stakeholders as possible in this project. When we identified the problem, we said, well, it's not only about training doctors, right? Because if a person with an intellectual disability goes to a hospital or a care service, it's not the doctor the first person that they're going to meet. So we will need to train and support also frontline staff of hospitals, for example, or nurses, specialized nurses or nurses in general. So we tried to have all the professionals in the healthcare sector involved and also work on a second sometimes parallel path, which shouldn't be parallel because they should work together, is the social system. Because very often a person with an intellectual disability is accompanied to a service, to a healthcare service by a social worker, often an educator or a psychologist sometimes. So we need to cover also professional supporters that are not in the healthcare sector so that they could work better with the healthcare sector, because this was one of the main problems that we had identified in the project. How did we do that? Well, as mentioned before, we developed trainings, mainly trainings, online trainings to support these different target groups. We identified the needs of this target group during the project by interviewing, well, the final users, meaning people with intellectual disabilities, around 120 of them, 180 healthcare staff professionals, 125 professional supporters, meaning educators and social workers, to understand their needs, and accordingly we have developed online training, online training courses, specifically focusing on what they asked us to focus on. So clear communication, that was discussed before, clear communication, how to communicate clearly with a person with an intellectual disability, how to remind ourselves that we need to communicate with a person with intellectual disability and not just with the family, not just with the professional supporter, but to have them as a key, well, the main decision maker, right? And how to support that decision making. Also, maybe it's surprising, maybe it's not, basic understanding of what intellectual disability is. We cannot take that for granted, even for specialized nurses, sometimes they didn't have any training on that. And the third model was a selection of good practices in general in service and healthcare, and some relevant legal frameworks in the different countries. Time is ticking, and I keeping an eye on the time. Maybe what I would like to focus on is the impact that we think we had with the project, right? So we developed trainings. You will find the trainings. I'll share the QR code at the end of the presentation. We are downstairs at a table if you want to. There is also Panita Bol, the manager of the project, actually here with us, and downstairs, so we can give you more information on the training. But how did this have an impact? Did it have an impact? We are happy to say that we think it had an impact. We piloted the training with well, hundreds of people, and we are happy to say that the vast majority of them said that 70% of healthcare professionals said that they improved their communication skills, for example. So they are happy to do this training and find it effective. Or students that are becoming nurses, they say that the competences are improved by 30%. So in general, it proved successful. The feedback is that it was successful. How did it impact at national national level. I will start with Lithuania. There we have a very committed partner, well, in all the countries, but also in Lithuania, of course, the University of Kaunas. They have made the training compulsory for students that want to become occupational therapists. Also, other universities in Lithuania have integrated the content of the project into surgical nursing courses, and they have developed a new non-formal education program that includes the content of the equal treatment project. So now the content is accredited at national level. What happened in Finland, the Tampere University has made the training mandatory for their nursing students, and since the project is over, we're talking about the end of 2024, around 450 students it's mandatory, so they had to take the training, meaning that it had an impact, at least in Finland, of course. What happened in Spain? Well, I would be happy to leave the stage for our colleagues here, but it's not possible. The course is now mandatory for all nursing staff within the intellectual disability service at IAS through the hospital that was partner in the project. Also in Greece there, even though the context is a little bit more difficult there, they're trying to promote as much as possible the content, and it's luckily enough it's in line with the priorities at national level in terms of disability. Why am I focusing on that? Because I think that the main message is when we have these projects, in this case, we were able to root the content as much as possible in the needs of all the stakeholders involved. So let's remember that we need to involve all stakeholders, not just doctors, but we're not talking just about medical stuff. And try to have an impact, try to make sure that when the project is over, well, through the commitment of our members, our partners, we are happy to say that we had an impact, make sure that the results are used, right? So in this case, you can see that in many European projects, you can see that the project, once the project is over and the content is dead. That is a waste of public money. You will not have an impact. We believe that having a proper exploitation and motivation of the partners helped us have instead an impact at national level. When it comes to European...
Hola! Buen día!
Hola. When it comes, there's a video in the presentation, you will find it in the website as well. When it comes to the European level, we're happy to say that we try to involve again as many stakeholders as possible. The European Specialized Nurses Organization was part of the advisory board. The Inclusion Europe, which is the official body representing people with intellectual disabilities at European level, joined forces with us on the policy recommendations. They joined the events of the project. HOPE is the Hospitals Federation at European level. So we try to involve as many stakeholders at European level as possible. And also we are happy to say that we received a positive feedback from WHO Europe, and the policy recommendations developed by the project are in a way included now in the document, the policy documents that they are now developing. That was a rush, but I think I made it in the 8 minutes, so I'm very happy.
Thank you very much. I think it is difficult to wrap up. But as so far everybody is so disciplined, we might get extra time to discuss. And now I'm happy to introduce Heather. And we listen to Heather and her campaign. We do it based on an interview which is already also written. Heather, can you tell us about your campaign for people who have a learning disability in Scotland to access annual health checks?
For many years, Enablement's campaign for better access to health care for people who have a learning disability in Scotland. Research by the University of Glasgow found that the average person with a learning disability in Scotland dies 20 years earlier than the population average, and are 3 times more likely to die of cancer. These are really exciting, frightening statistics. They are not affordable, and it's not fair, it's not okay. The impact of lack of good health care for people who have a learning disability was particularly clear during the COVID pandemic, when people in Scotland who have a learning disability were twice as likely to catch COVID and 3 times more likely to die in England. Because of this, we campaigned really hard for every person with a learning disability to have access to an annual health check. The idea behind annual health checks is to identify any illness or health complications early so they can be treated quickly and before they got worse. In 2022, the Scottish Government agreed with us and provided funding for every single person with a learning disability to access an annual health check.
So, does this mean everyone in Scotland is now getting an annual health check?
I really wish that was true, but unfortunately it hasn't happened. After 2 years, I still haven't received an annual health check, despite this being promised. From speaking to fellow self-advocates and able, it became clear that many lives still had never been invited for a health check. Despite being a government policy with funding to support it, many local health practices said they were not offering health checks, and it was a struggle to get an appointment. Some people thought they must not be entitled to a health check and stopped asking. A journalist found out about this and investigated it. They found that in 2024, only 6% of people who have learning disability and were entitled to an annual health check actually got one. Self-advocates at Enable worked with journalists and politicians to press the Scottish Government and local health boards to fix this. We wanted to make sure that everyone who has a learning disability knew that they were entitled to a health check. I was confident enough to ask my doctor for mine, because I knew I should be getting it.
Heather, there is a particular challenge for women who have a learning disability to access checks and screening. Can you tell us about the work you have done for women with a learning disability to understand cervical cancer screening?
Data collected by health boards in Scotland show that women who have a learning disability are far less likely to attend cancer screening checks than the general population. In Glasgow, 65% of women went for a smear test for cervical cancer in 2023, but only 27% of women who have a learning disability got one check. Not getting checked can mean missing the chance to treat cancer early, to stop it getting worse, and to save lives. Because too many people who have a learning disability are diagnosed late. They are 3 times more likely to die of cancer than the total population. When we started talking about this at our self-advocacy forum, none of our self-advocates, including me, knew what a smear test was. Some people who have a learning disability were scared to get tested, and some people had been told by the doctors that they don't need to get one. I was very anxious and embarrassed to get my first smear test. At Enable, we worked with a charity called Joe's Trust, which wanted to help us encourage women to get checked. We had awareness sessions and focus groups for women who have a learning disability, and we used prompts to understand what happens when you go for a test and why it's important to get checked. I worked with Joe's Trust and was able to get some films for women with a learning disability to teach them about cervical cancer and going for smear tests. After learning so much and engaging in all the sessions, I was more comfortable with the idea of going for my test. The second time was much easier as I knew what to expect, And this time I knew I could bring someone with me. So I brought my mum. The doctor said I was the best patient she ever had because I was so calm and knew what was happening. The doctor said she thought she saw something unusual, which needed checked. Fortunately, the results came back and everything was normal. But that's why it's so important that I went for a test. We now combine our campaigning for annual health checks with raising awareness for cancer testing for women and for men as well. Our recommendation to health boards is to use annual health checks as an opportunity to discuss, encourage, and arrange cancer screening for people who have a learning disability. It's a really important measure and it will literally save people's lives.
Thank you so much, Heather, for sharing your campaign. I think these 4 examples show the width of the field we have entered. And there are so many points. We are challenged. We are challenged to provide equal access to just normal medical care. We have to provide more knowledge and expertise in the field of healthcare professionals, but we also have to focus on places where specialists can do special work for people with special needs. And this is not contradictory. Broad access and high specialization belong to each other. Now, there are a few times, there are a few questions possible. I think it's always good to let the audience have a question. Is there anyone who has a question?
Should we do the summary first or the questions first?
I will do the summary at the end because
Okay.
the summary is the summary.
Okay.
And the question might add important information. If nobody starts, I will start. But there's one hand. Please, you are the first. But while you're getting to a mic, or come in front, while you're coming in front or getting a mic, I just one question. There are 2 trainings programs. How many hours do staff in a medical setting have to invest to complete your program and to complete your program? How many hours do you train nurses on the job and how many hours do you plan in your program? Very simple question, very simple answer.
Yes, in our case, we have a 10 hours training program in
10
a
hours.
virtual campus in the university.
10 hours.
I must say that I'm not sure about the final answer on that because it was discussed during the project and I said that I think that with the higher education institutions in the project said that they would not fix a specific number of hours because it may differ in different countries. Consider that it's international, so it may differ in different countries. So we don't have a set number. Huh?
I asked the question because I'm a medical doctor involved in universities and also responsible. I know how stressed healthcare is, and you don't get slots easily. But one thing I want to ask you as well, are the teachers people with experience themselves in your program,
Can you repeat, because I was
Yeah.
talking with,
Oh,
sorry.
yeah. I understand. It's so interesting.
Yeah.
No, in your program, are you also involving teachers like Heather, who is an expert by experience, to teach the medical professionals in your program,
Yes, in our case, the instructor are 2 psychologists, a psychopedagogue, and a graduate in special education from Fundación Personas, in a training program in 4 blocks.
Okay, but the question was, Heather is a real expert.
Yes,
She
of course.
teaches us what she really wanted. And I got the experience that is extremely helpful to have these teachers paid as a salary as our teachers. Is that the plan in your program?
So in this specific project, we involved people with intellectual disabilities in defining the needs and the content for the training, but not consider that it's online training, so we don't have trainers, right? It's a self-e-learning module, so people go online and do the training there. We identified the content that needed to be put there by involving also people with intellectual disabilities, and in general, we had a co-production protocol in the project to make sure that we involved people with intellectual disabilities that have, as you are saying, the experience of the other ones that live the situation, so that to make sure that they would be involved in every aspect of the project.
I just mentioned that because I could start a medical program, and in the first week of students, I employed 4 teachers by experience as the best lecturers for medical doctors. And the audience is quiet and the students are open, but I'm not the person. They are the teachers and they get it through. Other questions, and the lady has got a mic in the meantime.
Yes, hi. Thank you for those really insightful programs, and it's really exciting to see, you know, lots of collaboration going on as well. How do you see these types of programs collaborating with the private sector, for example, and how, you know, the private sector can also get involved in supporting and educating healthcare professionals as well?
Mm-hmm. Perhaps I try to give an answer. The private healthcare sector is difficult to access. I think our best chances are students in the beginning. And there are wonderful doctors who do great services and others do not. And mandatory, you can achieve some regulations on buildings, but not on the hearts. And that is a very important point, that each one has to work on his field, even in dentistry. I think if we're realistic, we need places like that as special units, because general dentistry is also very stressed and doesn't respond to it. Is that the same in Israel?
Yes, it's the same, but that's why we teach students, like you said. So they absorb it very well, the knowledge, and it's a part of them.
I think it is fantastic if young doctors and young nurses and healthcare professionals get awareness and learn to know where places are, where the environment and the staff and everything is appropriately prepared to serve that population with specific skills. Another question, we have still time for questions. The first question was here and here and here. I think that will be possible. Please.
Hello, I have a question that comes from the notion that we've seen that one of the core aspects is that people with disabilities know about their rights and know that they can request certain kind of health measures or interactions. So do you know of any programs or any initiatives where doctors take on that responsibility to also educate disabled people on their rights and give them the knowledge to kind of advocate for themselves also outside of those specialized places that are not always accessible to everyone?
I don't know if I understood it correctly. The question was about health literacy, health competency, and training towards that huge dimension. Okay.
In the case of the specific project, I was mentioning before that we try to target also the social workers, and if I think about your question, I'm thinking more about actually usually social workers and educators, not the doctors, right? That train well, not necessarily, but often the person with an intellectual disability on their rights. So in that case, in the project, the module for professional supporters were dedicated to supporting the rights of a person with an intellectual disability when going to a hospital. What are their rights? How can we promote that? So yes, in this specific project, I would say so. It's true. Well, we have other initiatives on that specific area. We are co-financed by Citizenship, Equality, Rights and Values as EPR, which is a program that supports rights, as the name says. So we have other initiatives more in that direction.
I think that's a wonderful question to Heather. Because you, Heather, campaigned for getting the smear test. How did you know about that? Who taught you about preventive checkups?
We were very lucky to work with a charity called George Truck, and through them we kind of knew about smear tests, because obviously I knew about it before, but I wasn't confident enough to go for a smear test. It wasn't until we did our work with George Truck and we were able to get our members to go for a smear test, and good. So if anyone's on YouTube, there's a video on YouTube about the work that we did with the smear test. So if anyone wants to watch that video, and you'll, hopefully we can get the link out to you, and hopefully, yeah, so that's how I knew about smear tests and stuff, through my work with George Truck.
So somebody taught it to you and you took it up?
Yeah, I was quite nervous at first to go for a smear test, but through my work with George Truck, so I kind of got more confident and I was able to take my mum and thankful I did, because I found an issue, but luckily I don't think I would have found that issue if I hadn't gone for the work with George Truck or if I hadn't got checked. But it's really important for any women who have a disability or anyone else in general, make sure you go for a smear test. I can't emphasize it enough. But yeah, so that's how I knew about smear tests.
What we also heard, that the parents played a role in health literacy. So let's strengthen the parents. Then there was another question. Okay. So we put the questions outside the room, but we will stand together there. After we have finished the session, we stay outside. And if there are questions, we will be very happy to meet. Now we get a summary, a visual summary.
Okay, I have to move in front of you, but you should be able to see a little bit on the screen. Thank you. Okay, in the center of this session were, of course, people with intellectual disabilities. So from when we talk about stakeholders, I think I have to move a bit more. I'm so sorry, I have to move in front of you, because otherwise, yeah, okay. So people with intellectual disabilities are in the center of this session. But there are so many stakeholders involved when we talk about access to healthcare for people with intellectual disabilities. Right now, we talked about families, parents, who are, of course, important to be educated. That was one of the last questions. Health literacy for people with intellectual disabilities. And the measures we heard, I try to summarize, was that it's, I think, most important to have a more human factor involved in healthcare, especially when we talk about anxiety, when you're going to the dentist. Provide comfort and care. Take time so that you can speak to the patient. And what the measures all did, being on the national level in Spain or also on the European level, was to teach healthcare professionals. And here we talk about frontline staff, as well as, of course, all the healthcare professionals, doctors, psychiatrists, or whoever is involved, and also social workers. So everybody who is involved in the whole process of taking care must be educated on the needs of people with intellectual disabilities. From what we learned, the teachers for now are professionals. They're not self-advocates for now, but maybe this is one thing that you can implement in the future. And I think one of the most important messages we received from Heather, you told us that people with intellectual disabilities have a higher likelihood of an early death. For instance, also for cancer. And so your message is that there must be equal access to annual health checks. For instance, smear checks for women, cancer screening, so that people with intellectual disabilities have the same access to prevention as people without intellectual disabilities. And unfortunately, equality has not been reached yet. But with all the measures we've heard, with all the training, with all the taking care of the patients, also reducing anesthesia, not knocking people out, but making them an equal person you talk to, can help to increase access to healthcare by adapting the system. That's the summary.
Thank you so much, and thank you to everybody who attended that meeting, because indirectly you are all improving access to healthcare, the place you are and the place you go to. All the best, and we will be outside for further discussions, and we leave the room exactly in time for the next session. Thank you so much.